in this fourth presentation, we will focus on the new oral anticoagulants for coronary artery disease. Is it a new paradigm in our practice? So I am really pleased to participate in this session dedicated to atherothrombosis, to acute coronary syndromes. And as an introduction, here in this presentation, we will focus on secondary prevention. We will focus on the recurrent events, on the residual risk after an acute coronary syndrome, after a PCI. This residual risks ranges from 1 to more than 10% in the registries. So what is the role of DOAC in this setting? So 3 pathways were explored, were investigated. The COX-1 for aspirin, the ADP-P2Y12 pathway also, with the 3 molecules, clopidogrel, ticagrelor, and prasugrel for secondary prevention. But the third one, this is the pathway of thrombin, which will interest us in this presentation. So DOAC will target the 10 factor, the 2 factor, and will stop the coagulation cascade. But also, by inhibiting 10 and 2 factors, and by the, through the PAR1 and PAR2 receptors on white blood cells, new oral anticoagulants will decrease the amount of cytokine, pro-inflammatory and pro-thrombotic cytokine production. So through this pathological mechanism, we will investigate the role of DOAC in 3 situations: acute coronary syndromes, chronic coronary syndromes, and after PCI in the setting of atrial fibrillation. So let's start, and chronically, investigators started by 2 major trials in acute coronary syndrome setting. This is the first one, the UPRISE study. So the UPRISE 2 study was published in 2011 and was a negative study. So association of apixaban low dose 2.5 twice a day with aspirin quickly after acute coronary syndrome did not result in improvement in ischemic outpoints, but it was associated with major bleedings, and the study was stopped because of a net harm in this study and because of multiplication of major bleeding by an amount of, by a factor of 2.6 versus placebo. So this study was negative and was early stopped. So is DOAC dead for secondary prevention? We will see that it is not the case. So the second study is the Atlas ACS2, more recent, published in 20,000, always in NEJM. And this study was positive, and rivaroxaban did better than placebo in the setting of acute coronary syndrome for prevention of recurrent ischemic events. So this is a positive study, but at the cost always of major harm because of major bleedings. As you can see, there is 3 to 4 false multiplication of major bleedings and cranial events, bleedings, by association of rivaroxaban with conventional regimen, a DAPT of aspirin and clopidogrel at that time. So this study was positive for ischemic event, negative for hemorrhagic major event and intracranial event, but we learned much from this study. We learned that a dose of 2.5 twice daily decreased mortality at 2 years. So association of a very low dose of apixaban, 2.5 twice daily, decreased mortality, and in the arm of 5 twice daily, mortality was not decreased because of hemorrhage and adverse complication. So this dose, you must retain, will be called after that the vascular dose, the very little dose of apixaban, 2.5 twice daily, is the very low dose, the vascular dose. Also, we will see that for rivaroxaban. So in the setting, to conclude, of acute coronary syndrome, association of NOAC with DAPT did not do better for outcomes, especially for major bleedings at 1 and at 2 years, and studies were negative in this situation. So in 2017, a study called COMPASS was published in the NEJM and treated about patients with chronic coronary syndrome. So this is a different design, as you will see. So this is a design of association of rivaroxaban with a single antiplatelet therapy after 12 months. So patients have a conventional DAPT till the 12 months, and after that, he will have either rivaroxaban, a small dose of 2.5 twice daily or 5 twice daily, in association with a single antiplatelet therapy. But after 12 months, as I said. So this study was the first positive study, and this study was stopped because of net benefit, especially on mortality. So COMPASS changed guidelines. COMPASS impacted guidelines by this 24% relative reduction of ischemic events when rivaroxaban was associated with aspirin after 12 months for long-term antithrombotic regimen. This was at the cost of a little increase in major bleedings, but there was no fatal bleedings and no increasing in intracranial hemorrhage. So this study was really promising for NOAC in the setting of chronic coronary syndrome, and it diminished mortality, it diminished stroke, and it diminished in borderline significance myocardial infarction. So COMPASS impacted guidelines, and there is a long regimen with rivaroxaban, 2.5 twice daily in association with aspirin for patients with either very high risk of ischemia or patient with moderate risk of ischemia after 12 months, and these are the criteria: diabetic patient, patient with peripheral artery disease, multivessel patients, patient with complex procedures such as CTO, left main, rotablation, bifurcation to stent, etc. So COMPASS was really a new paradigm in NOAC indications. So I will finish with the atrial fibrillation setting after PCI. So 4 pivotal trials, and the meta-analysis of these 4 pivotal trials showed a net benefit on major bleeding with a little increase, but it was not significant of stent thrombosis when we use NOAC in the setting of AF and the APT with a single antiplatelet medication. So NOAC with clopidogrel does better than VKA with the APT, the conventional strategy, by reducing hemorrhage, intracranial hemorrhage, major hemorrhage, without an increase in ischemic risk, except for a little trend of increasing of stent thrombosis. So NOAC in AF patient undergoing PCI is an indication 1A, and it should be stopped with a FIRE trial 12 months. The antiplatelet therapy should be stopped 12 months after PCI, and we should only continue with NOAC better than VKA after 12 months for secondary events. So extension for LV thrombus, extension for peripheral artery disease. This is a good niche for NOAC in long-term management. So key messages: we speak about residual risk, DAT, so dual anti-thrombotic therapy or dual inhibition pathway with NOAC is efficacious versus the APT, and vascular dose of rivaroxaban 2.5 twice daily is a good option for long-term management and for prevention of secondary ischemic events. So do not associate NOAC with dual antiplatelet therapy only for 1 week or only for 1 month after PCI in AF patients. Do not go more than 1 month. DOAC should be associated with a single antiplatelet therapy, especially and better with clopidogrel than with potent antiplatelet prasugrel and ticagrelor. And the antiplatelet therapy in the setting of AF should be stopped at 12 months. And the niche of peripheral artery disease, I think that we have a lot of patients with polyvascular disease, and it deserves treatment with NOAC with the vascular dose. Thank you.